yet another ball game. So we have Dr. R. Ramakrishnan, my chief and my mentor, for talking about the phacotrabeculectomy in angle closure disease. Let's hear us from the stalwart, Professor Dr. Ramakrishnan, sir. For want of time, we'll take questions in the end if possible. So we'll go on to the next talk.
Good morning, everybody. At the outset, I would like to thank AIOS and the local organizing committee for wonderful arrangement. And also I have to thank Madhavi for giving the opportunity. And of course, management of glaucoma itself is a very challenging problem in the field of ophthalmology. That too, management of angle closure glaucoma is much more challenging. That we have seen in the previous speaker by Mohideen, Devendra, Indra, Sharmila. All are very, very difficult situations. And of course, the glaucoma is not normal eye. Any type of glaucoma, it's open angular angle closure, it's a sick eye. It's not coming. Shall we put it here? No. Yeah. Okay, thank you. Okay, yeah. So it's a sick eye. It's angle closure glaucoma. When compared to open glaucoma, it's different in so many ways. So number one is very small when compared to, because accident is very, very short, and chamber is very shallow, and the angle is very close, and the thick sclera and choroid, which leads to a lot of other post-operative complications like suprachoroidal hemorrhage or ovial effusion. And most of the times, the people will be very small, mid-dilated people. It's very, very difficult to work in a mid-dilated people in a very crowded anterior chamber. And also, intraocular pressure most of the time to be very high, and also prone to many complications. So now the important thing in managing glaucoma, any form of glaucoma, especially angle closure glaucoma, we are not afford to make any complications during surgery, because it will completely affect the outcome of the surgery, because post-operatively patient can go for so many untoward incidents like what Mohideen has pointed out in his talk. And also relative pupillary block, one of the important, because when you diagnose angle closure glaucoma, because there are so many other varieties. So primary angle closure glaucoma, it's most of the time is with the pupillary, so commonly with the relative pupillary block. And without a relative pupillary block, you see your plateau iris syndrome. That also, because about 25 to 30% of the angle closure glaucoma, what we normally see in our day-to-day practice, tend to be, unless we do a thorough investigation, will we see plateau iris syndrome or configuration. And laser radiotomy, as pointed out by Devendra, so the important treatment modality for angle closure glaucoma, it has got, because surgery is not that easy in angle closure glaucoma. So mainly it's in the early stages laser radiotomy, and in some other cases where IOP is not controlled, medical management is very, very essential. And of course, if it is not controlled, depending upon the lens situation and the level of intraocular pressure, either we can go for a trabeculectomy alone, or the intraocular pressure is very high and not controlled with medication, with operable cataract, we can go for a combined surgery. Then factors other than IOP, as I already mentioned, plateau iris configuration, and also the changes in the lens thickness and its position. And iris volume also plays a major role. So now the study done by Quickly found out that the choroidal thick expansion and iris volume and thickness also plays a major role in the angle closure glaucoma. And lens thickness and position, age is age-related growth of lens, and especially nuclear sclerosis and changes in lens position due to zonal laxity, and of course, role of lens already dealt by our Devendra. And coming to the management, because all of you know very well glaucoma management, three modalities: medical, laser, and surgical. And of course, laser has got a wonderful place in the management of angle glaucoma. Of course, medical management in early stages with moderate intraocular pressure with the clear lens, it has got very good result. It can be one or two medication, but especially in places like country like us, where the patient cannot afford to use more than 2 or 3 medications continuously for lifelong, is very, very difficult because of the cost. And also another important aspect is the poor compliance of the patient, whatever may be the economical background of the patient, the compliance is very, very poor in due course of time. And also not only that, even a good compliant patient, rich patient, suppose they have the effect on the drug, then it's very, very difficult to control the intraocular pressure. Then, of course, laser adaptive, the efficacy is one thing we have to, it's not uniform in all the patient, not all the, depends upon the stages of the disease. And also need for medications definitely needed. And is cataract surgery alone is enough, because there are so many studies have been done, and usually they will temporarily reduce intraocular pressure, and although it seems to have no effect on diurnal IOP, but the intraocular pressure reduction after cataract surgery alone is transient, temporary, and it will, most of the studies show that it will last for about 1 or 2 years. After that, it will come to the baseline. And so, and also the intraocular pressure reduction also depends upon the it's not hard and fast rule. It depends upon the stage of the disease, and also the thickness of the lens and amount of angle closure ranges from 2 to 12 millimeter of mercury. And of course, phacotrabeculectomy has advantages over phacoemulsification for the treatment of primary angle closure glaucoma, in terms of better IOP reduction, and also the reduced number of medication post-operatively to control the intraocular pressure. But one of the important things we have to keep it in mind is the complications. The complications are very, very high if you do a combined phacotrabeculectomy when compared to simple cataract extraction alone, because of the you can have a shallow chamber or choroidal detachment or malignant glaucoma, because malignant glaucoma is one of the important things we have to keep it in mind in angle closure when you manage the angle closure glaucoma. And of course, when we have to do phacotrabeculectomy, because the as already mentioned, it's the ocular hypertension effect of simple cataract extraction is very, very short, lasts for short time, and reaches baseline within 1 year or 2 years. But in cases with refractory glaucoma, that means so if the intraocular pressure is not controlled with 2 or 3 medications, with a patent iridotomy and a progressive visual field loss and visually significant cataract, then there is no other option. We have to combine with cataract extraction with some of the anti-glaucoma procedure, mainly because the golden procedure is the trabeculectomy. So, what are the indications? I already mentioned failure of medical therapy and intolerance to medication. Suppose they are not able to tolerate the medical antihypertensive agents, and advanced disease, and also the disease is progressing, then we have to go for phacotrabeculectomy. It's the same thing. It's combined phaco has got a better IOP control when compared to cataract extraction alone. But what the start, it's not a simple journey in doing phacotrabeculectomy in cases with angle closure glaucoma. So, of course, it is not the advantage of a single procedure, but patient is more convenient, and also reduced cost. The need come for frequent surgery, and avoid potential IOP spike following the cataract surgery. And of course, in most of the cases, you can have a long-term intraocular pressure control. But again, it's on the other hand, it has got some of the disadvantage, like the challenging is to perform. That's what we have seen in the previous speaker. They presented how it is very difficult, and also some more prone to have a more intraoperative and post-operative complications, and a long surgical time. You have to be very, very patient. Like Moidin Lord has shown one of the case of post-acute attack, how we remove the lens. You have to be very, very patient. Then otherwise we will end up in a problem. And also long time for visual. It will take a long time for the visual occurring. And also it's before going for cataract surgery, we have to prepare the patient to be it's a thorough preoperative evaluation, a slit-lamp examination, gonioscopy, and even intraocular pressure, all these things, and also location of the PA. Suppose if a PA is about 9 or 3 or 10, don't, but advice is not to enter the chamber at that area, otherwise the iris will prolapse over the, and also assess the number of anti-glaucoma medications. Two things, one is we used to stop all the anti-glaucoma medication at least 5 to 7 days prior to the combined surgery. This is mainly to keep the eye quiet, because following anti-glaucoma medications, there are so much of changes happening in the eye. That's conjunctival, that the goblet cell will come down and increase the population of the fibroblasts, and chance of scarring of the future blood is very, very high. So we normally used to stop anti-glaucoma medications and to give some weak steroids for about 1 week, so that you can have a better blood formation after surgery. And second important thing, especially in angle closure, in a simple cataract surgery, we want to stop blood thinners like clopidogrel or aspirin. But in cases with combined surgery, it's always to stop this blood thinners, so that you can avoid uninterrupted bleeding during surgery. And of course, the assess the pupillary dilatation is very, very important, because most of the people will be very small, and you have to use the pupil expanders or iris hook to dilate the pupil, and look for phacodonesis, and in some cases we may need this CTR, capsular tension ring, and and already, as you mentioned, you have to reduce intraocular pressure to the maximum. You have to give intravenous mannitol, Diamox, or Volgulsa, because you have to have a soft eye during surgery. Suppose if you have a hard eye, the intraocular pressure is very high, then it's very, very difficult to proceed with the surgery. And intraoperative, you can use intraoperative agents to dilate the pupil, and also adequate viscoelastic. Do not overfill the antechamber, then again you will have a problem. And of course, iris hook and to turn blue to this one. And always I prefer to do a twin site phacotrabeculectomy in angle closure glaucoma, because single site, especially superior, is very, very difficult, because you want to have a much work. You will not be convenient and not comfortable in doing single site in the superior. So you just do a phaco in the temporal side, and do the trabeculectomy in the superior, so that the manipulation will be very minimal, and you will have a better blood formation post-operatively. And also this all the complications. Also, of course, because of want of time, I'm not able to show the video. I will skip that video. And the post-operative management, as usual, we have to give steroids for much more time, because of the increased post-operative inflammation along with the cycloplegics. Otherwise, all other management like laser suture lysis or digital massage are almost equal to same as other phaco triple. So to conclude, always rule out pupil block in any case of angle closure glaucoma, and rule out prior to iris, and consider lens removal or combined surgery in any case of angle closure glaucoma with a significant cataract. And of course, it's beneficial for good and long-term intraocular pressure control, and you have to have adequate precaution and preparation preoperatively, intraoperatively, and postoperatively, so that you can have a very good outcome following surgery. Thank you.